Okay, chapter 15 of the ACE 6th edition, Certified Personal Trainer Certification textbook. And chapter 15 is on considerations for clients with musculoskeletal issues. This is actually really good chapter, very helpful, because if you're going to see anything, now look, you've looked at some chronic disease issues that people have. We do see a lot of musculoskeletal issues, and that's why this is a really important chapter. And the way it's going to be set up for you is it's going to be common injuries and reactions to healing. It's a good idea to understand the three phases of the process for injuries and preventing musculoskeletal injury. So you got prevention, you got program considerations, um, common conditions of the upper, and then conditions of the spine, and then common conditions of the lower. So ACE is trying to cover all the bases here with what you'll probably see in some way, shape, or form. Of course, not all of them, but for sure you'll see a number of these issues. So first thing to start off with are what's known as the reactions to healing and acute and chronic injuries. And so what is the physiology of healing? So what you'll want to do is for sure look at the three stages of healing. The inflammation, right? Phase one is inflammation, and that's that initial onset of the actual whatever the injury was. And so you're going to get inflammation or an inflammatory response. Page 682 has a really good picture, figure 15.1. That's a pretty swollen ankle, just so you know. And this is the normal reaction to an injury, particularly at a joint. And this is the soft tissue is able to expand and accommodate this increase in the inflammatory response. Phase two is now the repair. So the injury inflammation normally immobilizes a joint. If you've ever, how many times have you like jammed your finger and man, it hurts. And then it swells up and you can't bend your finger. If you've ever done it, I've done it a number of times, right? It's like that at pretty much any and every joint. Whenever there's a injury, if your wrist swells up, that swelling actually acts to immobilize the joint. So phase two can start the repair process. And then the repair process leads then to remodeling, kind of overlaps with the repair process. And that could take up to 3, 4, 5, 6 weeks, or even longer. But table 15.1 gives you those three stages. And then the idea that there is a progression of exercise after the injury. Look, as with everything else that we talk with these last couple of chapters, you always got to keep in mind that we only do those things that we as trainers within our scope of practice are really capable of doing. And you got to know your particular level of expertise. If you've been doing this for 20 years and you've seen this over and over, you get a pretty good idea of how you're going to deal with some of these issues. If you're new, and you don't have any experience with this, you just completely acquiesce to what what the physicians are telling people. Because for the most part, if it's really this bad, depending on the injury, they're going and getting it checked out and taken care of. On the other hand, people that twist their ankle may not go to the doctor and they just kind of say, look, I hurt my ankle or I hurt my wrist or whatever the case is, and I'm not going to be able to train tonight. Okay, I get it. Normally, they'll basically, most folks will basically say, I'm just going to ice it and take some over-the-counter meds. The idea, though, is that there is a actual structured way in which the body deals with acute injuries, and it's through these three stages of healing, and then the role of pain, which most of us don't want pain, but it's going to happen when you get injured. And you need to be able to deal with and understand, and that's what you're going to see, by the way, as we get further along into this, is that there's a scale. On a scale of 1 to 10, where is the pain? Now, you can do this not only during the training itself, but you can just get a basic idea of even when the client first walks in. We're concerned more about when it's actually during the training process, after the injury has gone through the healing. If the wrist, if it was a wrist injury or shoulder injury and you're doing movements, and it is a little bit painful. Look, if you've ever been to physical therapy, they're going to tell you it's going to hurt. Just gonna let your road know right now, it's gonna be painful. Now, just got to make sure we understand where that pain is coming from, and that's kind of what we're dealing with: recognition and action, common acute injuries. So muscle strains and ligament sprains. There are different grades of both a muscle. Remember, muscles strain, ST, ligaments sprain, SP. Okay, so muscle strain, ligament sprain, and they go from grade 1, 2 to 3 in severity. And of course, table 15.2 gives you a list of what the actual impairment is, and the acute care. So RICE, right? Rest, um, RICE. That's the acronym that's used, or the acrostic that's used when you have any issue like this. So compression, elevation, those are the things that go along with these common injuries. So you have muscle strains and ligament sprains. Read through those tables, make sure you understand what those all mean. The healing process itself for a muscle strain, generally a lot less than a ligament sprain. Again, depends on the grade, right? Grade 1 muscle strain, most folks aren't even going to the doctor for that. It's painful, it's uncomfortable, but it's mild. It's not that bad. It could just basically be a pull, right? What we call a pull. You pulled your bicep or whatever. A day or two or not training or working on that muscle will deal with that. But a grade 3 muscle strain, that's you're going to the doctor for that. Cartilage damage, bone fractures, these conditions or issues. It's a good idea to read through it and just know what the actual condition is. We know what bone fractures are, and we know that, for instance, they need immediate care. Cartilage damage. Remember, cartilage, hyaline cartilage, is the smooth, hard substance that covers the what's known as the epiphyseal surfaces of bones. Wherever you have a joint, you've got cartilage, particularly joints that are moving, right? And cartilage is what allows for the smooth rolling and movement and rotation of joints, of the joints themselves. And so that's important, because cartilage can be damaged. It can be worn away. And if it gets worn away, underneath the cartilage is the living tissue of the bone, and there's pain sensors in there. And so if cartilage wears away and then you have bone on bone, ooh, that's very painful. So keep that in mind. So head, neck, and back injuries, that's the recognition of these injuries and referral to a physician is essential. Concussions, now again, it's not that you're not going to see them. I don't think I've ever had a client have a concussion in the years I've been training, but it could happen. And basically, what a concussion is an injury to the brain, and there's a change in mental status. That's basically what a concussion is. It's a brain injury. It's a brain injury. I remember I had one when I was playing football when I was younger. I got clobbered, and I don't remember a whole lot, but there was a clear injury to my brain and a change in mental status, and maybe even till today. But there's confusion, disorientation, and you just need to know that those are the basic signs and symptoms. The idea is we're not going to train people if they have a concussion, but if they come in and they did have an issue or problem, at least you would be aware of what the potential issue is. But that's going to a medical professional. Any of these injuries, obviously, we're going to get people to go to the to their doctor, whatever the case is, or the emergency room if it's bad enough. So acute neck and back injuries. Um, there can be muscle strains. There can be, as you see on page 6 to 88, issues with the vertebral column. You can have clients actually, while they're training, I've seen this happen, have a intervertebral disc bulge or even rupture during particular exercises when they're holding their breath. The Valsalva maneuver. It increases that intrathoracic pressure, and discs are they're pretty tough. They are pretty tough. But there's other things you can do. You can get into the wrong position. Flexion of the spine combined with the Valsalva maneuver, combined with resistance, like on a leg press, for instance. All of those, all of all the moons start to align and pop. You can have this lateral herniation of an intervertebral disc. And normally, what the client will feel if that does happen is they feel pain, sharp pain, and then they feel a sort of warm, really uncomfortable feeling that gets worse when they turn or move. Emergency room, that's what you're going to do. You're basically calling 911 anyway. Now we come to what you're going to see probably more than anything are the common overuse conditions. So tendonitis, bursitis, and fasciitis. Itis, itis, at the end of the word simply means inflammation of. So inflammation of a tendon, inflammation of the bursar sac, and inflammation of the fascia. Again, normally we're going to see these in those particular movements where you're doing the exercises. So you might get tendonitis in the elbow. You can be lateral on the lateral epicondyle. It could be medial, right? Tennis elbow. These are conditions. The IT band down by the hip, right? The iliotibial band. These are, I hate to use the word common, but they are common when you're dealing with the average person who's never trained before, who sits a lot. These are common overuse conditions. And again, it just occurs over time. They could be doing the same thing over and over. Here's my mouse, right? If I'm doing this all day, all day, all day, what's going to end up happening? Some of you probably already feel it or know this. You start to get wrist issues, right? You can get carpal tunnel syndrome. You start to get numbing and stuff. All of these little issues is what your clients bring to you. Now, is it going to cause issues and problems with training? It may, but look, I don't want to be training people if they have if they have an injury in their wrist, or they have tendonitis in their shoulder or their elbow, or they have fasciitis in their foot, which is where you commonly see it. So you just need to know what they are, and how you're going to deal with them. Stress fractures. Um, and again, and I'll just go back to this. The idea is that any type of inflammation is a response to some sort of injury, even if it's a chronic overuse situation that leads to essentially this painful condition. It's not an acute tearing of a tendon. It's not an acute, right, rupturing of the fascial uh, coating underneath at the bottom of the foot. But it is this chronic, long-term condition from doing the same things over and over and over again, that now create inflammation. And inflammation is just, again, it's a reaction to something that's going wrong. And your goal is to obviously be able to train around it, and help and assist the individual as necessary, particularly if they're not going to the doctor for it. But that's one of those things that I normally just acquiesce and say, look, go see your primary care doc, and have him look at it, because it may just be one of those things where he says, whatever, take some aspirin or over the counter meds, and then be careful when you're training, because that's really what we're talking about, right? Don't go all the way down. Don't extend all the way down. Don't go all the way up. You got to limit range of motion. Um, and warming up, of course, is very, very important. Stress fracture. Again, whether or not you're actually going to see this in an actual training scenario, I don't know. But how do you prevent musculoskeletal injuries? Well, one of the things you always got to keep in mind when it comes to musculoskeletal injuries is, was there a preliminary condition problem related to flexibility or elasticity of the soft tissue? And that's often what you'll see for people that are inactive, is that they have poor flexibility because they never stretch, right? And they get into these dysfunctional positions because they're like this for 10 hours a day, right? Doing this on their mouse pad, and general elasticity because of age. These are the things that you have to consider, right? So in order to ensure, the prevention is really warm up and appropriate recovery. It's it's intuitive. We warm up to increase core body temperature, and then do a site-specific warm-up to increase the actual temperature of that particular area. And we also develop an increased neuromuscular sort of activation when we do warm up prior to really working the muscle harder. So we're taking it from this rested state and just incrementally moving it into a higher level of physical capability. And that's what warm-ups do. Increase core body temperature and simultaneously increase sort of this neuromuscular facilitation capability, because now the muscle is going to have to work harder when you're actually training them. So combine, by the way, combine the warm-up with some stretching afterwards, and now you're kind of prepping, the neuromuscular system, musculoskeletal system for these higher levels. And that's one of the ways you can prevent basic injury. So the muscle that is warmed up has more pliability, has more elasticity to it. Okay. And then of course, proper recovery. If you don't recover and then you go back in, you're ripe for injury. And so proper recovery, allowing time for recovery, these are critical. So what are the programming considerations for clients then? First and foremost, you got to know the pain scale. On a scale of 1 to 10, where you at? You know, 5. Oh, say, whoa. Okay, stop. Okay, we don't want you to be at a 5 or a 6. Okay, yeah, but I need to work through it. No, you did that with your physical therapist. Okay, he's the one that broke the adhesions and is doing all that. You're at a 3 or 4. That's going to be the recommendation. So explain to the client before starting, that the affected area, may hurt, may be challenged, of course, obviously. Explain the scale 0 to 10, 0, nothing. 10 is the worst pain you have ever felt in your entire life, right? Mild discomfort is at 2, 1, 2. And then 3 to 4, 3 to 5, somewhere around that is moderate pain. That's probably a problem, particularly if you've recovered, you've gone through therapy, whatever the case is, and now you're coming and it's time to train. When you're at 4 and 5, that may be a little high, and then just encourage the client to communicate any amount of pain. Right into a movement method. Remember, read through the ABC approach. Not a bad idea, of course. Once again, good conversation samples on these 2 pages. And then acute injuries. Now, right back to your table 15.3, muscular and cardiorespiratory training considerations for post-rehab. Big thing right now, post-rehabilitation. And so the idea is that you have a type of acute injury, right? Acute is a sudden onset. You broke your arm, you tore a ligament, whatever the case is. That's an acute injury versus chronic, right? Something like tendonitis or bursitis. Those are chronic, right? They take a long time to occur, and they just continue on. Table 15.3 gives you some basic guidelines. Now, again, as with the tables that have a lot of written material on them, I do recommend, yes, that you rewrite it, but make sure you understand, what the correlations are. Again, some of this is just intuitive. Lower extremity injury, right? A lower extremity injury will affect the kinetic chain in all weight bearing movements. But what's the muscular training guidelines? Well, upper body, seated or lying exercises are fine. What about cardiorespiratory training? Well, remember, a lot of what we do for cardio training involves the lower body, because that's where the majority of the large muscles are. Okay, well, in that case, it would make sense to do some water training if you could. Upper body ergometer, right? Nothing with the legs. Now, we know that the ergometer does not get the heart rate up as high, but for the average person, it's better than nothing. Perhaps the recumbent bike or station out. By the way, that depends on the lower extremity injury. So just keep that in mind. Some of this is intuitive. If I said, I got busted up my knee, I came to you for training, I busted up my knee, and well, let's go ahead and get on the treadmill. That doesn't make any sense, right? So it's intuitive. Let's try something that reduces the weight and pounding on the feet. So we're going to do something seated. That's why the chart is intuitive. I hope you get that. Chronic injuries and conditions, basic questions that you should ask your clients, right? how did the original injury occur? Again, this makes sense. I had a client once who, and this has happened a number of times. This one sticks out in my brain. I had a client once who was doing squats, and for some reason didn't have any issues until we got to a certain weight, and it was bothering him on the outside of his knee. And I asked him what it was, and we just couldn't figure it out. And I finally just thought, I said, "Did you ever have an injury?" And he says, "Oh, yeah, I've had tons of injuries, but specifically." And he told me, yes, when he was like 8 years old or 9 years old, he had gotten hit on this, and it kind of dawned on me. Well, of course, there was sustained damage to his knee. That was never a big deal until we really forced the issue and put a lot of stress on it. I've had clients tell me about shoulder issues. They never put it on their pre-assessment screening forms. They never told me about it because it happened when they were 10 or when they were 12. Oh yeah, right. I fell out of a tree, but I was fine. I broke my collarbone, and I like, well, wait a minute, you broke your collarbone. Well, no wonder when we're doing bench presses and we're really starting to work hard, no wonder now all of a sudden you kind of quote, wake up that injury. You'd be surprised. So, did you ever have an injury in your hip or whatever the case is? It's a good question to ask. And that's what those questions are basically giving you. So again, you got the warm up, establishing goals. These are all components of what you need to be doing with your client. And by the way, the apply what you know box here on page 696, 697 is a good one. Is a good one to read. Very, very helpful. Now, of course, we're moving to another movement method on page 699. Remember, the warm up is essential, critical. Cool down is also very, very important. So static stretching, and then of course recovery. These are important things to keep in mind as well. And by the way, that material that we just glossed right over, you've already gone through it in previous chapters. Again, what ACE has done is it's moving material back, kind of back and forth, so you can see some of it, you learned it, and then the application of it, and it starts to make sense. So if you went through and you said, well, wait a minute, we talked about, yeah, but now this is within the context of this particular chapter. So common conditions. Now we're moving into that this other part of the chapter where you're going to see some common conditions, not all the conditions, and you may never see any of these conditions, but these are the quote common conditions of the upper extremity, and they're always going to be related to the particular joints of the body. So in the shoulder joint, you're going to see any number, right? Impingement syndromes are fairly common. If I've seen one issue and problem, it's been impingement syndrome for sure. Bursitis in the shoulder, AC joint issues, things like that. And what are the program designs for these particular conditions? Again, you got bullet points here on page 704. So consider the following steps when selecting exercises for improving shoulder function. Again, remember, this is where you are taking these bullet points and you're writing them down. It's intuitive. It makes sense. It really does. What about at the elbow, the wrist, and the hand? Okay. Again, these are, I say common, um, but again, you might see clients that come in and that just kind of, they go, yeah, I mean, my wrist hurts a little, sometimes. Do you have carpal tunnel syndrome? Well, yes, well, that's really helpful to let me know that you have carpal tunnel syndrome, because the idea then is that we have to make modifications to your program. Not you know, drastic compensations, but we do need to say, instead of holding the barbell like this or the dumbbells like this, it's going to be something as simple as pronating, going into a neutrally pronated position. Ow, this hurts. Ow, ow, boom, that doesn't hurt. Ow. Well, that would have made sense right from the get-go if I had already known. And instead of watching you drop you can imagine some of these basic things that if you knew, you can make very, very simple, quick adjustments. Okay, look, because you have carpal tunnel syndrome, what we're going to do is we're going to kind of keep a neutral grip. Try not to let your wrist drop back like this or come forward this way. By the way, let's try it with your thumb out this way and see if that helps. Does that help? Oh, wow, that's a huge difference. You're a champion when you do things like that. So how about for the uh, spine? So starting at the neck, there are some common conditions of the spine, and figure 1514 gives you this. You've seen this before. This is where a lot of folks, by the way, if they're looking up a lot like this, they tend to jut the head forward. So there are these movement pattern dysfunctions that occur because of the way people have their head positioned, for instance, and that's fairly common. Okay, so you got the neck. Uh, Consider the following steps. Again, you've got 3 bullet points. Observe the relationship of neck position to that of the thoracic spine. Introduce gentle movement, stretching. These are the things you've got to consider. What about the lower back? We've said this before, and you've learned this in the previous chapters. The lower back, that is one of the most common reasons people go to their doctor. In fact, I think it's like 80% of all primary care physician visits are due to low back pain. So this has got to tell you something, and you've got table 15.4. It's just giving you a little understanding here of the muscles. By the way, this will help you with other with other issues related to the overactive and underactive muscles that we talk about with these postural dysfunctions and dynamic movement assessments. So, it's a good idea to memorize table 15.4 and what those particular muscles and muscle groups do kinesiologically or their function, right? Program design, again, the apply what you know is on page 710 and 711 is really what you actually want to look at, because that's going to be very helpful. And memorize the names of each of these: the cat cow, the modified curl up, the bird dog, and the side bridge. For sure, know those, understand what they entail, how to do them. Very importantly, apply what you know component. Um, and then again, considerations. Moving into common conditions of the lower extremity, starting at the hip. It's going to be the same thing. Piriformis syndrome, for instance, is relatively common that you're going to see. Arthritis, people that have hip replacements. Again, any of these issues, you are acquiescing to the clinical world first. And by the way, even the physical therapist, and I've been saying doctor, medical, quite often in cases of musculoskeletal stuff, you're actually talking to the individual's chiropractor, if that's who they went to, or you're taking information back from the physical therapist, which is what a lot of people are going to see. And use the physical therapist to your advantage, because they're much closer in knowledge base and understanding of the musculoskeletal system, obviously, than just a physician. So you got program design for the hip, for the knee. All of these are essential components that need to be considered and seen and looked at and understood. Again, as you're going through the chapter, you have a number of these different conditions. It's not all the conditions, but it is a pretty good overview of the ones that you would be seeing. So patellofemoral pain syndrome, all of these can be related to genetic issues, for instance, and just lack of physical activity. Knee arthritis, again, knee replacement. And there are program considerations to look at. Now, I will say this. When you look at these bullet points, like on page 721, consider the following steps when selecting. One of the first things that you're going to see is first address any imbalance between the right and left side. So when we're looking at lower extremity stuff, particularly the knees, you got to really be careful and look at any abnormalities or gross deviations for both sides. It's actually important. And then here are your exercises, right? Body weight squats, cable squats with the full explanation of how to do it. And then, of course, the ankle and the lower leg. Shin splints, again, relatively common. We see this in particular type of sports or individuals that do a lot of walking. Just as a for instance, that could be some of the issues that you'll see, but there are specific, again, specific exercises that you can do. So figure 1537 standing calf stretches. We would put these in normal training sessions anyway. Remember, we're talking about specific issues, but in reality, I'm stretching my clients' calves no matter what. It's just critical in here, and this is actually going to benefit them. Ankle sprains, one of the biggest problems you're going to see. And let's look specifically here at figure 1540, and we see this all the time. It's one of the worst things that I've seen trainers do with clients. First off, we just never do frontal plane movements like this, side lunges. I'll say this, I've said it 1,000 times. There's no such thing as a side lunge. There are single leg squats where what you're doing is you're stressing the lateral component of the ankle joint. It's just not a good exercise. I always recommend to trainers, don't be doing these things. Lunges are forward and backward, and that's the only way they're ever done. And here is a classic biomechanical reason why the problems that occur are it's just unnecessary. So yeah, read through that. Really, really important. And again, plantar fasciitis. This is one of those issues that, for the most part, can be really, really uncomfortable for your clients. And so there are ways you are not treating and dealing with this. These are things that can come up, and you can guide your clients on. And again, great chapter. Lots of really good information here in chapter 15. And just keep this in mind. You're always acquiescing to the clinical community. If people have come to you with these particular issues and problems, that's one thing. They would have already gotten information from their physical therapist or their doctor on the things they ought to be doing. This chapter is really opening up your eyes and opening up your world a little bit to see the actual conditions that you're probably going to see while you're training people. So that's the end of chapter 15, and I look forward to seeing you in chapter 16.